Lisa Cochran, I'm the Service Manager for Inspiring Lancashire. I work for CGL, who's a leading national charity working with vulnerable people around addiction, homelessness and domestic abuse. CGL support 115,000 people nationally over 160 locations. Lancashire services were recommissioned and Inspire was successful in taking over the contracts from the 1st of October 2018 in North and Central Lancashire. Inspire is made up of a number of partners, so CGL being one of them, and a number of subcontractors that will deliver different elements of the service. It's an integrated drug and alcohol treatment service, and we deliver from a number of community venues and also have hubs in Fleetwood, St Anne's, Lancaster, Morecambe, Preston, Chorley and Skelmersdale. Our aim is to support people to achieve and sustain recovery, as well as reducing harm to individuals, their families, communities and society as a whole. The treatment that Inspire deliver is open to anybody who's affected by drugs or alcohol at any level. What you can expect when you walk through the door is a personalised assessment that's based upon your own needs, a service user plan that's tailored to meet those needs, and there's various different treatment options available to you. That includes psychosocial interventions which can be delivered through a group on a one-to-one basis or through digital means. We also have opportunities for prescribing, opiate replacement therapy prescribing, community detox options, inpatient detox options and treatment pathways to residential rehab. There's volunteering and peer mentoring opportunities available to people once they have achieved some stability and want to give back. An exciting element of our new model is the number of subcontractors that we are working in partnership with in North and Central Lancashire. These include The Well, Red Rose Recovery, Active Lancashire, Emerging Futures, Recovery Works and Acpeer Recovery. The new U team is going to support people to build recovery capital, and that is, as we know, the more recovery capital an individual has, the more likely they are to achieve and sustain recovery. The opportunities that the new U team are going to bring is family support and mutual aid, housing support options for poor people who are still using substances and are in recovery, improved physical and mental health and well-being. There's volunteering and mentoring opportunities, education, training and employment opportunities, peer support and mutual aid, additional support when people are in times of crisis, and there's an opportunity to earn time credits all the way through that. Here at Inspire we work with a great team of people that's made up of a multidisciplinary of professional backgrounds which include consultants, medics, nurses, healthcare assistants, key workers, administrators and managers. One of our key priorities is to work in the integrated care systems with primary care and develop those relationships to meet the local health needs of our communities.
My name is Dr. Abby Goli. I'm the Regional Lead Consultant for Inspire CGL Lancashire. I'm really excited about this addiction services in Lancashire, in particular the North and Central region, and the innovation and the new ways of working we're going to bring into this region. Optimising one's treatment for opiates will be one of the key things in addressing the bigger issue which we all face with our patients. I want to broaden our offer on alcohol, in particular bringing alcohol detoxes, reducing the harm related to alcohol in the region. I would want to closely work with the primary care, secondary care services and other agencies to fight this battle of reducing the harm in our local populations and patients. Furthermore, I would want to broaden our experience in dealing with complex mental health and physical health issues which bring in with the addiction issues. I want to introduce our naloxone offer for our individuals. Basically, I would want to identify all the people who are at risk of an overdose from drugs, or in particular from opiates. We want to flood the streets of Lancashire with naloxone, train people up, including the patients and the carers and families, and give naloxone kits out to should there be an emergency. I would also want to bring your attention to the recent research done by AdFarm around children and their families dealing with addiction. We want to broaden our offer around reducing the harm to children and also safeguard our individuals and our young people in the region.
My name's Samantha Watson. I'm the lead nurse for North and Central Lancashire. I've been asked to give a brief overview of naloxone. So what is naloxone? Naloxone is a life-saving drug that we give out to our service users. It's used in an opiate overdose. What naloxone does is it attaches itself to the receptors. It's very, very short acting, so it only lasts for 20 minutes. And there's 5 doses in a kit, so that buys us time to make sure that we've called the ambulance service and that they can arrive within a timely manner. So the box it comes in is yellow, just like this, and we use the 3 twist rule. So you twist the box to open it, you take out the vial, you twist the top off the vial, and then you would twist the needle onto the vial. Once you've done that, you must always pull this twist and pull away from yourself so not to give any sharp injuries. This then acts as a cradle once you've administered it into the top of the thigh of a person who is in the recovery position. This is then put back into the cradle and can be given to the ambulance service once they arrive. We give these kits out to all our service users. We would give out 2 kits per time, per training. If service users use them, we would ask them to bring them back and we will replenish their stocks. And we don't ask any questions. We train professionals, service users, and partner agencies in the administration of naloxone.
My name's Michelle. I'm a volunteer at CGL now. I've been volunteering for about 3 years. I came through service 5 years ago, maybe 5.5 years ago. I was referred off a counsellor. I had a lot going on, been through a lot in my life. I started drinking from the age of about 14, drinking and just smoking. Started the rave scene, went through the rave scene for a good 10 years. Pretty much lived for the weekends, amphetamine, ecstasy, cannabis during the week. I had my daughter at 31, and that was a big factor in I'd never been shown how to be a mum, and I didn't have the best of mothers, and it was pretty much a hard thing to do, and like a big change in my life. Probably it's the biggest change that I've ever been through. I pretty much felt like I was stuck. I didn't know what to do. I did start drinking because that was the only thing I knew how to do, because I didn't know how to control my feelings, the way I was feeling. I was abused as a child sexually. I struggled with an eating disorder. I had lots of mental health issues that I hadn't got help with. I hadn't spoken to anyone about. My mood was really low, really scruffy. I was like a tramp. Even drinking Frosty Jack, I was a tramp. But my daughter was looked after, and one thing I do, because she was only small, and it is a guilt thing for me, but I never neglected her, and it was always, she was always looked after. Anyway, I went to college, Preston College, did an access to social work. I was still drinking a little bit, not probably a bottle of wine at night, red wine. And that basically got me to sleep. But I got up next day, did a day's work, and that become a way of that's what I did. When I brought it up with my counsellor, it was on the last session, she'd kept over the week, she said, over the week you've brought this one thing and it's something I feel like it's bothering you. Do you want me to make a referral? And at the beginning it was putting me into groups. Well, what's that going to do? I want you to stop me drinking. But it's not like that. I came in and it's been a long, slow process of 5 years of why, what are your triggers and how do you keep yourself safe and the learning the relapse prevention and all the preventions that have come with the groups, and I've done a whole load of things that I never thought I'd do. So now I'm a volunteer myself, and I've done motivational interviewing, which I'm loving. Motivating people once you're active in your head and you're active in your body, and trying to keep everything positive that I do. And I run a women's group, I'm running a singing and dancing group this afternoon, and just people telling me I'm doing a good job and thanks and I'll see you next week. That motivates me to keep doing what I'm doing. You smile at someone smiles back at you.
We're talking about supervised consumption SLA, and we realise how valuable supervised consumption as a tool is to safeguard our individuals. We do know that pharmacists are an invaluable resource in identifying our patient problems, in particular understanding their day-to-day things, drug-seeking behaviours, the state they are observed in, and often look for signs of overdose and intoxication. Supervised consumption helps not only to safeguard people but also observe the response of this medication on the individual. Monitoring of missed doses and, if necessary, withholding this treatment is vital and is in the interest of service user and their safety. As part of the service level agreement for supervised consumption, it is vital that we all work together, in particularly in terms of understanding one's regular dispensing of medication or whether one is missing doses regularly. We do recognize that missing doses is often a sign of disengagement. It is important that we understand the reasons for one's missing doses. You might be already aware that an individual missing more than 3 days of medication can reduce their tolerance levels and the risks escalate. This might mean that they may have to be restarted back from a lower dose and titrated upwards. I can't stress enough how important it is that we all work collaboratively in this journey for our patients.
Our community needle exchange service level agreement allows us to provide needle exchange provision in the aim to protect health and reduce the rate of bloodborne virus infections and drug-related deaths among our service users. It does this by reducing the rate of sharing and other high-risk injecting behaviours, by providing sterile injecting equipment and paraphernalia and other support, promoting safer injecting practices, and by providing and reinforcing harm reduction messages including safe sex advice and advice on overdose prevention, especially around the risks of polydrug use and alcohol misuse. Community needle exchange is an important role in providing our harm reduction advice to our service users, and it maximises the access to services for service users, paying special care to those highly socially excluded. It provides a convenient needle exchange service that you can access without an appointment, and it targets priority groups. A key delivery aspect of the needle exchange in the community pharmacies is around overdose awareness and offering naloxone where available or signposting them to more local services. Other health interventions such as smoking cessation advice and screening for COPD can be undertaken when people are accessing this service. It's important that reminders for appointment with health services are provided through needle exchange services, and brief interventions around drug and alcohol misuse are delivered.
As some of you are already doing, shared care clinics run in practices integrated into existing practice systems. They provide specialist care to our patients at no cost to the surgery. Shared care clinics can be linked with existing primary care clinics and can have easy access to practice nurses, health visitors, sexual health clinics, etc. Service users are seen to be caring for themselves more in this holistic way, which includes their general health and social care. When taking patients onto the shared care provision, there are certain criteria we follow. One of the main things is the person's willingness to be part of this service, to be looking at facilities available within the primary care settings to offer this service, suitable room within the practice, and allocation of a case coordinator to regularly monitor one's drug use. It is also seen that the shared care GPs would undertake Royal College of General Practitioners Certificate in the Management of Drug Misuse Part 1 and subsequent training and refresher training from the CGL services. This not only facilitates partnership working but also brings all elements of care under one roof. As you know, part of the Public Health England agenda, we will be aiming for 10% of planned opiate discharges from treatment to allow further referrals into primary care provision. There are two elements to this shared care provision. One is level 1, where GP provides treatment to the patients registered in their own practice, and level 2 is where they deliver treatment to service users from other practices that are not delivering shared care services. GPs signed up to provide level 2 service are required to ensure seamless communication systems between their practice and their registered practice. CGL as a service offers free CPD sessions for all Lancashire shared care providers and aims to look at one's development and update knowledge in this area of medicine. There are CPD monthly meetings held at Phoenix Mill in Manchester and can look at confirming attendance by contacting myself via email abhishek.golly@cgl.org.uk.
What you need to know: all claims must be submitted through Farm Outcomes. Claims must be submitted by the 5th of each month in order to receive payment within 30 days of invoice date. In order to support payments, pharmacies must share their bank details on company letter-headed paper and send to finance@cgl.org.uk. Any finance queries to be directed to Mr. Stephen Lonergan. Any contract queries, please contact GP Pharmacy Quality and Governance Manager Liz.Hopkins@cgl.org.uk.